Good afternoon. Again, my name is Tanya Winders, and I'm the president and CEO of Allergy and Asthma Network, and it's our pleasure to welcome you today to Asthma, COVID, and Questions We Need Answered. This is the first webinar in a series of 6 that we are calling Black People Like Me. And this virtual conference session was funded through a Patient-Centered Outcomes Research Institute Eugene Washington Award. We'd like to thank PCORI for the opportunity to engage each of you this afternoon as we talk about asthma, COVID, and questions that are specific to the African American Black community. So as we get started today, first, I want to introduce you to some very important people and also outline our agenda and our objectives. At Allergy and Asthma Network, we have been dedicated to ending needless death and suffering since 1985 in asthma, allergies, and related conditions. It's through our efforts in outreach, education, advocacy, and research that we achieve this mission. It is a multidisciplinary stakeholder network comprised of over 2 million Americans, just like you and just like me. And today we are excited to address this exciting agenda and the objectives that are described in this slide. So as you can see, we will start out by talking about an introduction to asthma and disparities in the African American community. Then we'll move to a COVID-19 update and tips specifically from a COVID-19 survivor. And then we'll also leave time at the end of our discussion today for some questions and answers. Our objectives for our time together are to describe the challenges that Black Americans face in managing their health. And oftentimes we know that this can lead to COVID-19 complications, but also asthma, COPD, and other underlying respiratory condition complications. We also will discuss questions that Black Americans need answered regarding their health. And then we'll also have a word from Dr. Reverend Michael Stinson, who will help us to examine the role of clergy in helping Black Americans to take charge of their health and to continue to advance the optimal health outcomes in our community. So as we get started, I want to introduce you to a few of my friends who are around the table today. First, I'd like to introduce you to Dr. Leroy Graham. Dr. Graham is going to be joining us on the phone, and he is a pediatric pulmonologist that is coming to us from Atlanta, Georgia, where he has run the largest pediatric pulmonology practice for decades, and just recently retired. So he may actually be coming to us today from Destin, Florida, where he is now making his retirement home. But Dr. Graham has been instrumental in the community of pediatric respiratory medicine, and also advancing specifically a program called Not One More Life that you all will hear more about today. Then I'd like to introduce you to Charmaine. Charmaine is one of our patient advisors and our project advisor group members. Charmaine works with Allergy and Asthma Network, has lived with asthma for most of her life, as well as a caregiver for those that are living with asthma. So we'll hear from Charmaine in a bit. And then we have Sandra, who is a patient and a special guest speaker that will share her experience and her husband's experience of actually living with COVID, of going through that experience of having the virus and recovering from the virus. We're also very honored to have with us Edwin Kellen Bolden. Edwin Bolden, the father of Edwin Kellen Bolden, was a patient advisor and patient project advisor group member. Mr. Edwin is going to share their family's journey of living with asthma and ultimately their loss of living with asthma. And so we appreciate Mr. Bolden being here with us today. And then our final project advisor group member who's present is Dr. Reverend Michael Stinson. And as I said before, Dr. Stinson is going to be able to share his unique perspective as a clergy, as a trusted messenger in the Black community, specifically in the Atlanta area, and how he has partnered to advance health outcomes in his community. And I believe that we also have Dr. Graham now on camera. And so with that, I'm going to go ahead and turn it over to Dr. Graham and ask him to take it from here. Dr. Graham?
Hello?
Yes, we can hear you. Go ahead.
Hello?
Yes, can you hear us? Dr. Graham, we can hear you.
I can barely hear you.
Okay, it must be your volume because we can hear you just fine. So please continue on. We've got your first slide up on why we are here.
Okay, can you hear me?
Yes, we can.
Okay, I apologize to everybody for the inconvenience of this. Technology sometimes is the best of us. It's worked very well for me, and I don't know what happened. We're going to get through this. So again, I am very happy to be here. I'm very happy to present something that's close to my heart and something that I've really been empowered by being with the network. So we're here to address problems of disparities. We don't pretend to have all the answers. We're not even sure we know all the questions, but we need your help. So this whole goal of this type of a program is to have you become part of the conversation. Advance the slide. Okay. So we're going to talk about asthma in the African American community, and we're going to talk about the health disparities that characterize that condition. So what does disparity mean? Disparities are differences, racial or ethnic, in the quality of healthcare that are not simply due to access-related factors, clinical needs, preferences, or appropriateness of intervention. The attainment of the highest level, the goal has to be that we attain the highest level of health for all people. And that's what health equity would be. And it requires us valuing everyone equally with focused societal, and I would add political efforts to address the avoidable inequalities that are both historical and contemporary, as are the injustices, and thereby eliminate healthcare and health and healthcare disparities. So if our goal is healthcare, if our goal is equity, then what we want to do is we want to get there, and we want to have it happen soon. So we have to look at what is the path to do that. Well, we know that there are discrimination and minority stressors. There are neighborhood conditions. There are housing inequities. There's food security, which quite frankly, in the present context, should be talked about as food scarcity. Just saw a report that up to 40% of American households are now facing food scarcity. Limited educational opportunities. We live in a system where the funding of our schools is inexorably tied to property values. So poorer neighborhoods have poorer quality schools. Many of the people who live here do not have stable job security and thereby have unstable income. And on the basis of all of this, we are still dealing with the fact that there's a deficiency in quality, affordable health care for people that are already stressed, as we discussed above. They're also exposed to environmental inequities in those communities. So these social determinants of health are conditions in the environment which people are born with, live with, learn, work, and play with, and worship with. And they cover a range of health, functioning, and quality of life outcomes and risk. And resources need to be poured in here to enhance the quality of life so that we can have a significant influence in improving these. Examples would be having access to safe and affordable housing, access to education that is appropriate and of quality and empowering people, have a situation or an environment that has public safety, available to healthy foods. And I'll stop right there. When I founded Not One More Life, I was working in a charitable health center in Southwest Atlanta, Georgia, breadbasket of our country. I was 8 miles from the nearest source of fresh food and vegetables within the city limits of Atlanta. Local emergency and health services are often deficient or delayed in these communities. And often these communities are close to environments that are toxic, so they have to be free from these kinds of environments. Right? So just some quick numbers. I won't read all this to you in the interest of time, but there are 25 million Americans with asthma. It's very prevalent, 10% of children, very costly. It's associated with over 3,000 deaths annually. And as a former asthma specialist, I would have to say that 99% of those are preventable because we have the disease, we have the education processes. This results in 14 million missed school days per year, making it second only to the common cold. And about the same in terms of the workplace, where again, second only to the common cold. More than 60% of the people are limited in their activity. Though the medicines are inhaled through fairly efficient inhaler devices, about 7 in 10 people misuse them or don't use them correctly. And then we have the issue that with formulary issues and breakage and coverage and so forth, we now have 1 in 5 people that we know cannot afford the basic medications for a disease that we know how to treat and we can treat oh so well. Well, these health disparities exist a lot among other areas other than just asthma. They're very apparent, however, in asthma care, and it's not acceptable. The time for change is now. And just look at utilization. African American children, almost 5 times as likely as their white counterparts to require ER care. Twice as likely, okay, in terms of African American adults, twice as likely in terms of Hispanics. But look at this, deaths. Deaths from a disease that absolutely no one should die. 7 times greater. 3 times greater in African American adults, 7 times greater in African American children, and twice as high in Hispanic children compared to majority populations. Money's about everything. Basically, if you have a higher income, okay, if you have a lower income, excuse me, you are actually more likely, with a breakpoint of about 75,000. Asthma is more prevalent in people with incomes below 75,000. If you didn't finish high school for a variety of reasons, you're more likely to have asthma. We know that people who have asthma earn less and are twice as likely to have an asthma flare that is disrupting their ability to be stable in their job or workplace. And then finally, 1 in 4 African Americans, 1 in 5 Hispanic Americans simply cannot afford the medicine. So we've done a lot of things over the years. However, the absence of disease does not automatically equate to good health. And we're not going to make asthma go away, but we have to deal with issues of access of care, simple things like transportation. People often malign patients with difficult to treat asthma as they miss appointments. Well, sometimes they simply don't have the transportation, and transportation infrastructure in some of their communities is problematic. Poverty. Poverty affects your access to health care and thereby health insurance. And as a result, low-income patients have to skimp, have to cut corners. Maybe don't take the preventive medication, take the inhaled steroid, but don't get that. Just get the albuterol, the quick fix. Environmental allergens. If you have a disease where a high percentage of the people are likely to have allergies or allergy tendencies at the same time, they live in polluted environments that are proliferate in terms of allergens and irritants. We know that vermin, we know that insect infestation, cigarette smoke, and then the fact that they're trapped, these houses are clustered in central traffic corridors of our big city. We found that in a study that we did when we had the Olympics in Atlanta, that during the time that everyone ride shared, everyone stayed off the highways and cut through Atlanta, there was a 60% drop in ER visits at the Children's Hospital at Grady Memorial Hospital, just decreasing that traffic because those people live so close to that dense traffic and the air quality issues that arise from that. Education inequality. You know, if you don't understand your disease, okay, that leads to problems such as using asthma inhalers incorrectly. And sometimes that education inequality is, quite frankly, the system and the provider's fault. Language and cultural differences. If we take care of a diverse population, we should at least be cognizant or aware of the cultural differences. Language barriers might be a problem, but there's interpreters. But we need to understand that some people do well with eye contact. Some people don't do well with eye contact. Some people found it disrespectful if you use Missy and surnames and things like that that might be offensive but seem right to you, or don't make eye contact. These are all things that culturally are deficiencies in the discourse between people. So the transfer of information doesn't occur. Go on. So how do we get here? We want to get to equity. So one of the things that we did, we were very fortunate to do something called the Not One More Life Trusted Messenger. Now, this was basically codifying what we had done for years in working with churches with a 20-year history of effectively programming pulmonary education and doing PFTs in high-risk communities, partnered primarily with communities of faith, schools, co-ops, and fraternal organizations. We did a brief, very brief, much shorter than this, and I'm struggling here, guys, because I don't have control like I do, but a brief educational didactic emphasizing need-to-know points, non-invasive health screenings, doing questionnaires, and then also doing spirometry in a lot of patients who, though they had asthma symptoms, never had a spirometry done. And then telehealth following up with high-risk groups. But most importantly, we help get these people into some source of healthcare. Next slide. All right, well, I'm going to be very, very happy to turn it over to my dear friend and Alpha fraternity brother, Reverend Michael Stinson. Thank you.
Reverend Stinson, if you could unmute your line, please.
Thank you, Dr. Graham. That was a great opening to help us understand asthma. Not only was I a physician for 16 years practicing medicine, but I'm also an asthma patient. As a physician, we learn about caring for the body, and that's all we think of. Now I've been the pastor for the last 14 years. When I began, I thought that I was just going to be caring for the spirit, but I realized that we needed to care for the entire being, mind, body, and spirit. You see, when Dr. Graham approached me in 2006 about Not One More Life to start on the board, I thought it was a great idea because that got me a chance to put my foot back in medicine because I wanted to care for people, whole people. You see, historically, people have turned to faith-based sources for churches, mosques, synagogues, but not just for spiritual enrichment, but also for information and for truth. Education has always been the key to advancement. So the church was looked to for education about what needed to be done, both in culturally, but also how to care for ourselves. When we find that asthma in people of color have increased adverse outcomes, we know that we need to do something about that. But not only does this happen with asthma, it also happens with COVID. You see, with COVID, people of color are more likely not only to get the disease, but to have adverse outcomes, longer sequelae, longer symptoms, but also death. You see, it's important that as people who are leading in faith-based organizations, that we pass this information on to others so that they can understand how they can better improve their health. It doesn't matter if you're great spiritually if your health doesn't work. It doesn't matter if you know a personal God if you can't breathe. Your quality of life goes down. In order to pass a true message of spirituality, we must also take care of the body. So I encourage my brothers and sisters who are people of faith and also who are leaders in congregations across this country to tune in to us here. We have 5 more sessions. If you didn't invite your congregation today, please invite them for the next one. Every month we'll have another session where you can hear what needs to be done so that we can have better outcomes, better health, and better lives. Thank you.
Thank you, Reverend Stinson. And back to you, Dr. Graham. Dr. Graham, you may be on mute. Dr. Graham. Back to you, Dr. Graham. I can see him, but apparently he's having a difficult time hearing us. Let's see. Dr. Graham? I have sent him a quick message letting him know that it's his turn to pick back up. Sorry about that.
Hello?
Yes, Dr. Graham?
Hello?
Yes, we can hear you. I'm not sure why he's having a hard time hearing
Hello?
us. Yes, we can hear you. Dr. Graham, we can
Hello,
hear
this is Dr. Graham again. We're now talking about the pathology of asthma, and we want to review, and I really do apologize for the technical issues. What we know is that in a normal state, the smooth muscle that surrounds our airways is relaxed, permitting airflow to move very, very easily. We know that when asthma is a chronic condition where the airways tend to be, to some extent, always inflamed, and as a result, very irritable. They become thickened, and they're very sensitive to things that might trigger the asthma attack. There's characterization by tight, smooth muscles, and air trap becomes trapped behind these blocked airways. Common asthma triggers are things that are very prevalent in most households, particularly when we have substandard housing. We may have problems with mold. We may have infestation of insects. Pets, we really try and make people make wise choices with pets, but pet dander can be very, very provocative to some patients. We also know that outdoor allergens, particularly in climates like places like Atlanta, where there's heavy vegetation all through the year, but then in other climates where people are just sensitive to what's growing in their environment. Secondhand smoke, even smoke, people say, well, I don't smoke around my child, but the child comes in and smells like cigarette smoke because the smoke is pervasive throughout. I talked about people in central traffic corridors often being adversely affected. And one of the things we know is about diesel exhaust. We took Atlanta, which has a lot of semis going through our city, crisscrossing and so forth. We know that diesel particulate matter and other kind of air pollution can be a very, very important trigger to patients with asthma. And then finally, in children and most adults, sometimes the triggering thing is just a cold, catching a cold, or maybe something more serious like a flu and a sinus infection. Exercise can also cause an asthma attack, but we find that if we get patients with asthma to get their asthma under control and go into some conditioning, exercise is not only possible, but is ideal as part of the management. Stress affects everything. When we have a disease that involves a lot of sensitivities and so forth, when we're anxious, when we're concerned, when we're frustrated with technology, as I've been, and I apologize again for that, okay, we know that that can be a trigger, okay? Cold air, but not just cold air, but the sudden change in temperature. A place like Atlanta, where it might be 70 degrees one day, or even my home in Chicago, and then maybe 30 degrees the next day. That change can also be provocative and can cause a flare of the asthma. That's a very important trigger. So it's estimated about 1 in 11 Americans have asthma, which makes it almost the most prevalent chronic disease that we face. And at least 5 of those, okay, so a little less than half of them really are uncontrolled if we apply what we know are the signs and the measurements of control. And as a result, they lose sleep from nighttime symptoms. They're unable to exercise without symptoms, missing school or work, going to an emergency room, okay? And oftentimes they over-rely on what we call the quick relief medicines, the albuterol, using those over and over again and not, or maybe not even having access to the chronic anti-inflammatories that would control their disease. So we see about the signs of symptoms are very common. So at this point, and again, I'm sorry for the delays and so forth, we're going to talk to Edwin. Edwin is the father of Kellen Bolden, and Kellen is the young man who we lost due to asthma. And I'll let Kellen's father share about that as much as he would like, okay? But it is in Kellen's memory that Not One More Life was formed, because we believe that this sweet child told us that really not one more life should die, or no, not one more child should lose their life due to asthma. So, Edwin, you take it from here.
Hello, everyone. Hope people can hear me. My name is Edwin Bolden. I do have a disease called asthma. I do flare from time to time, especially when weather change, being here in the South in Atlanta. I'm kind of nervous, don't know what to say, but I'm just going to speak from the heart here. I have a son. I had a son, Kellen Edwin Bolden, that passed away from asthma at age 11. He was diagnosed at the age of 5 months. We noticed he was breathing kind of funny. I knew it when I seen it. We went on through the procedure and took him to the hospital. And from 5 months to the age of 11, we was in the hospital most of all his life. And matter of fact, here in Atlanta, Scotts Wright Children's Hospital, our family was on first name basis with everyone there. That's how much we was there. And Dr. Graham was inspirational to us throughout the whole time. He took Kellen in his wings, and he really did everything he could do. Hats off to him. But unfortunately, we lost him to an asthma attack as he was getting off a school bus. I guess carbon monoxide might have triggered it. And it was rough, and it still is rough to the day. But I'm here to talk about education of asthma. Putting the word out, getting to the low level income areas, teaching people, giving classes, giving fairs where we can help people out, spread the word about asthma, because it's prevalent in the Black community. And we need to try to find a way to get this word out, because once again, asthma is a disease. And I just want to say that we need to be aware of it. We need to understand what it is we can do, how we can control it, how we can, once again, like I say, it's vital that we get in the community and really explain to people that doesn't have the hands-on like I may have had with asthma. And I guess I'm so nervous right now, but I won't sum it up in one word, so a few words. Not one more. I lost my son. Not one more. I deal with asthma every day. I deal with it every day. I'm on inhalers. I'm taking medicine. I'm doing all those things. But you can still, believe it or not, have a normal life with asthma if you're doing the right things. My son did things that we didn't think he'd do. He played football, and everybody knows that's a hard thing to do. But he was so hardcore about doing it that he did it. We had special stipulations for him, but he did it. So it is a disease, but it is a disease that can be controlled, that can be handled the right way, but we just need to be educational and get out to the community. I think that's about all I have to say at this moment. It's my first time, but once again, thank you for having me, and thank you for having me speaking out on it.
Thank you, Mr. Bolden. We really appreciate you being here and sharing not only your own experience, but also the legacy of Kellen and his life. And we're so grateful for the bravery that you and your wife have shown to continue to serve in the community and to bring that message forward of education. Dr. Graham, we'll have you continue on the treatment now.
Thank you, Tanya. Again, let's go back a little bit about how asthma is treated. Well, first we have to make a diagnosis, making sure it's asthma. There are other conditions, okay, that may mimic asthma, like COPD, or maybe just bad irritation due to something in the throat, anatomical things, all kinds of stuff. But mostly, you know, if it barks, it's probably a dog. And we see common recurrent symptoms of cough and audible wheezing at times. And it's important to realize that, because a lot of time is wasted just making the diagnosis. Once we made the diagnosis, it's a chronic inflammatory disease that we need to control. So we need to control that inflammation, and we have to have controller medications. And the key and most important point is that we basically have to use those every day. Now, that seems obvious, but we have to remind that to our patients. I always use the analogy of hypertension. You know, don't wait to have a stroke to take your hypertension medicine. It's something you take every day to prevent. Same analogy works for the controller medications. We need to have quick relief inhalers to use as needed when we do flare up, but we need to be mindful that if we're using that more than twice or more than 3 times, I used to tell my patients, in any given week, that means your asthma's out of control and you need to talk to your doctor. You need to see what's going wrong. And then we know that we get, with the advancement of science, we get into a lot of other treatments based on very, very severe asthma, and asthma that requires some very, very cutting edge medicines, the so-called biologics. But in reality, as a pediatric pulmonologist, I really feel that about 2/3 to 3/4 of asthma can be easily controlled with cleaning up the environment, taking a medicine continuously on a good, well-constructed regimen with a preventive medicine that prevents you from an asthma attack, your controller medication, and then having it access your rescue inhaler. And knowing that when you're using that rescue inhaler too much, that means either you're not taking your medicines or it's out of control. Get back to your provider. All of this is usually summarized in an asthma action plan. And we used to kind of quiz our patients on it, but it's what to do when you have a problem. And I have patients write it down, keep it in their pocket, make laminated cards. But you need to understand and address what your triggers are. No, every time I go over to grandma's house, you know, and she got that dog or that cat, you know, that's a trigger. Every time I get in a dusty environment, you know, lots of different things, maybe even foods. And you need to understand and address the triggers to the extent that you can kind of avoid those. Also a flu shot. And we're talking now about, you know, COVID and all the intricacies of that. And just let me just say, that's a whole nother discussion, but we as Black people, we need to get that immunization because we are suffering disproportionately. I know that's not the focus of this talk, but just let me say that. But the common everyday annual flu needs to be treated, needs to be prophylax needs to be get an immunization every year, okay? Because we know that if you get the flu, it affects the lining of the lungs and you're gonna have a flare-up of your asthma. So a flu shot should be done every year, okay? And the most important thing, and Edwin kind of touched on this, is, kind of learn everything about your asthma, make sure that the people around you are aware, okay, and know what's going on. All right, the goal of asthma control, and Tanya speed me up a little bit on the slides. I guess I'm trying to overcompensate for the fact that I can't get in as the rest of you are. Prevent chronic and disabling symptoms, okay? That's what we want to do. We want people not just, well, I take all this medicine, I can kind of make it to school and work, and then I kind of crash. No, we want you to have as normal a lifestyle as possible. So you want to prevent those chronic and disabling symptoms, and you have to let your provider know if you're taking the medicine, that's not happening. We also want to have normal lung function. That's an objective measurement of how well the asthma is being controlled. And it's important because studies show that when we don't maximize that lung function, we may actually result in people really developing much more of a chronic problem, even what they call the overlap syndrome, or chronic that overlaps with chronic obstructive pulmonary disease. We want to provide the best treatment with asthma medications, learning those medicines, making them accessible to people, people knowing how to use them. And the goal is not, again, to just kind of get by in life, but to have a completely normal activity level. Asthma in 99% of our patients, and I may go out on a limb and maybe some of my colleagues will disagree, but in the vast majority of patients with good medication, good use of cleaning up the environment, awareness of a plan, good communication with your physician, people can have normal activity levels. That should be the goal. And in doing that, you will prevent asthma flares and you will minimize the need for emergency room visits and hopefully eliminate hospitalizations, okay? And we want to meet what the family and the patient wants to live and what they want and how they want to live, which is to live without limits. And that's possible in the vast majority of patients with asthma.
Graham, thank you. We're going to pause for just a couple of minutes because we do have some questions coming through. We want to take this time maybe to answer a couple of those. So the first one is you clearly say here that this is a chronic condition, right? But sometimes it's hard to educate parents that asthma doesn't go away. They don't really understand that it can flare up at any time. How do you go about addressing this with families and really reinforcing that this disease is chronic at any time and can worsen at any time if you're not addressing that underlying inflammation?
Okay, I tell people it is a chronic disease. In most cases, asthma does not go away. I also try to emphasize that it's so important to maintain good control, because if you don't, that inflammation may lead to scarring and you may develop what we call fixed obstruction that looks more like someone with COPD, chronic bronchitis or emphysema. So I kind of implant that in the patient's mind, and I tell them, hey, you know what? Hold me as your provider. And this is something we didn't talk about. I'm going to go off script a little bit. You should respectfully hold your providers accountable for you doing better. If they're trying to sell you on this, it's going to do better, then, hey, doc, no, I'm not really better. And the lung function helps. But that's what we want to do. Okay. We want to provide the best treatment with asthma medications, but also the right amount of asthma medications. Sometimes when patients do get better, we don't reduce the medications appropriately. And then patients say, well, I don't want to take all of these. I'm feeling fine. So that's, again, a two-way communication between you and your provider. And then that goal, normal activity levels.
Right. And I was just going to say, sometimes we hear, and the point was brought up here in a question, that sometimes parents are still worried that even those controller meds might stunt growth in their child. So how do you really address that when you hear that concern?
Okay. First off, I say that with good asthma control, we're going to get by with just enough asthma controllers, just enough steroids to maintain that. And by getting that control, we're going to reduce the exposure to the inhaled steroids, which do have an impact on growth. But in most cases, in my experience, patients that I was able to achieve really good control on a reasonable dose of inhaled steroid and then back it down while monitoring them, both with my lung function testing and the feedback from the patient and the family, we were able to get patients off. I'll give you an example. There's several basketball players around Atlanta, some of them, in respect to privacy, I'm not going to names, who are now playing in college and one in the NBA. Okay, these people grew. They had horrible asthma. It did not stunt their growth.
And most of the time we see, right, it's like less than 1/4 of an inch over the lifetime that those steroids impact growth. So let's go to our first polling question. I'm going to initiate the poll. How many people die each day from asthma in the US? So I'm going to launch the poll. Those of you who are online, you can actually go ahead and log in your response. We'll give this just a few seconds and see. I see those numbers coming in. Again, we've got well over 550 people on the line this afternoon. So we'll give everybody just a moment to vote and see what the results show us here. Just a couple of seconds more. We really appreciate this interactive function of this webinar and discussion this afternoon. It makes it much more fun for everyone to participate. So we're going to end the poll and share the results. You can see here that in this instance that 3% thought it was 2 people, 16% thought 5, 41% answered 10, and about 40% answered 20. Dr. Graham, according to the statistics, what is the accurate answer in the US at this point?
I think the answer is close to 5 to 10.
Yeah, so it's
I haven't
about
seen
10
the most
people.
recent data.
Yeah, about 10 people a day still die due to asthma, unfortunately. So that's the latest data that we have based on the 2017 information. So tell us a little bit more about the Black people like me and some of the numbers and statistics that we've already talked about in the African American community.
Okay. Well, again, we see that each day, 10 Americans die from asthma. We've already shown that death is much more common in African Americans. And then we also stated that most of these deaths, if not all of these deaths, we've got many, I'm going to say close to all, are really preventable with proper treatment and care. And that's not just our medications, but cleaning up the environment, good compliance, healthy lifestyles. Adults, however, are 4 times more likely to die from asthma than children. And women, unfortunately, are more likely to die from asthma than men, and boys more likely than girls. There's an interesting flip there. But, you know, those are all, I would say, I mean, people quibble with this, and Tanya, I hope I'm not going out on the line, but I feel that almost all of these deaths are preventable. And again, we do have to deal with the sad fact that African Americans, adults and children, are more likely than other people to die of asthma. So that's why we have to take this very serious. So what are some of the strategies to change this paradigm of this kind of ugly, kind of depressing kind of picture? One, an attitude. And Kellen was so good about this. Kellen never said this, but this was Kellen. I have asthma, but asthma doesn't have me. This little guy, and Dad's told you he was always on the go. I mean, even when he was on a continuous nebulizer, he was planning what to do next. But there's some strategies that we were effective in, Kellen, you know, and we were effective in a lot of our patients to increase adherence. One, we as providers need to ask, you know, you walk in the room and say, you on your medicine? Yeah, I'm on my medicine. Okay, no, the chart says you're supposed to take such and such twice a day. Are you taking it twice a day? Sometimes I'd get tricky and I'd say, well, how many times a week are you missing it? You know, things like that. And sometimes the honesty would come out. But again, that single thing that the patient can do is take the medicine as the doctor's prescribed. Then we as providers, together with our patients, need to uncover what are the barriers to adherence. And adherence means sticking to it. Ambivalence. Sometimes the provider telegraphs kind of an ambivalent or I just got to get to the end of the day attitude, or the patient says, oh, you know, I got this asthma, but I'll be okay. You know, that's ambivalence. Fear and misinformation. Oh, babe, don't let them give that boy that steroids. You know, he's not going to grow. He's not going to do this. It's going to change his nature. And people know, Black people know what I mean with the nature. Okay. That kind of fear and misinformation is counterproductive, and it may be dangerous. Also, we as providers and the healthcare system, which is something in sole need of reform, needs to consider cost, but to the extent that we use resources wisely to get right people on the right medicine. To fight to get the right person on the right asthma to save a few $100s might lose a life, or may lead to an ICU admission, which is $3,000 to $4,000 just walking in the door. Also, we as providers need to talk about hassle factor. If we can simplify the treatment plan down to 2 things, or we can make it twice a day, or we can make it once a day, that's something we need to do, and to get into a partnership with the patient to make it easy. So it's not a hassle, but it is something you have to do every day. And then address the barriers. Straight talk. You know, I would tell the sullen teenager, okay, who would look at me and roll his eyes when I'm talking about, I said, you know, you can die. Or sometimes I would have the you're going to blank and die talk with people. And these were white kids and Black kids, okay? But eliminate the victim mentality. You know, I'd get the patients, oh, you know, I got asthma, can't do anything. No, you can do almost everything with it. And you can't be a victim. There's no situation in life when being a victim solves everything, or at least kind of taking that into yourself. Education, understanding what your asthma is, being able to, we used to have asthma camp, and we used to have kids as a kind of a spoof. We'd have kids teach each other about asthma. And it was great because some of these kids were rocket scientists. They were stars on this. Samples. The system has kind of made it hard for us to have samples, but studies show that if I prescribe a medication and I put it in that patient's hand, or that patient gets it that day and goes home and uses it, they're much more likely to continue it. So when samples were permitted, that was the kind of thing that made sense. And I see no reason why that shouldn't happen again. So anyway, I'm getting the slide changed, so I'm talking too long, but let's hear from Charmaine. She and her members of her family have asthma.
Thank you, Dr. Graham. So yes, I have asthma, and my children have asthma. The disease has always been a part of my life. It certainly has brought anger and frustration and sadness, because at times it often, can feel like it's kind of getting in the way of life. And as a young child, I remember, those repeated emergency visits to the doctor because I couldn't breathe. And then when I was young, inhalers weren't the norm. It was, head to the doctor to get a shot of epinephrine to help clear up your lungs. So looking back, I did have several asthma challenges as a child, but for me and my family, it was our normal. I lived in an apartment with my family. We had a pet dog. We had wall-to-wall carpeting and windows where you could feel the cold air in the winter, and you had to open them up in the summer to get some air. And we had occasional pests. My mother also smoked in my younger years, but after, repeatedly telling her, that I couldn't breathe or that the smell was awful, she quit after years of smoking. But then also growing up in my neighborhood, playing outdoors with friends until the streetlights came on was a way of life. The summertime heat and humidity and pollen were just conditions you lived with and lived in. And so there was no conversations also in my family about allergy triggers or things to avoid, or what we needed to do in our apartment that would help support living in an allergy-free home, or limiting my outdoor activities in poor air quality days to help lessen my asthma episodes. But then as a young adult, when the responsibility shifted to manage my own health care in a sense, I began to ask my doctor more questions. I wanted to understand what this asthma was and understand what my triggers were. And more importantly, how do I control it? I was also very active in school and found myself being very limited in some respects on not being able to participate on this day or that day because of my asthma episodes. And I think, overall, it resulted in just that level of understanding and having responsibility about my health. It gave me a sense of confidence about my health. Certainly, I was able to then kind of see life as one where it didn't, asthma didn't limit me pursuing, interests in areas that I wanted to be in or participate in due to quote unquote asthma fears. And I also find that, just having an understanding also helped me with my children, who now are at a point in their life where they too now manage their own care. So they have that understanding again of what it means to understand what your condition is, and not only be mindful of your triggers, but then also have a conversation with your physician to help control it through medication. And then lastly, I feel like just living with asthma, and I've again lived it my whole life. That's all I know. And certainly, again, limiting those contacts with the triggers, adhering to a treatment plan that you've talked to with your doctor, and certainly, prepare for the emergencies, because it's not to say that an occasional asthma attack won't happen. So always have, medication available. And I think someone alluded to in earlier parts of this presentation, to let people know that you have asthma. And I know there's a with that kind of growing up as an adolescent. It's kind of one of those things where you don't want to really tell everybody, but there's certainly folks that need in your kind of close circle of friends and or family members that certainly should know about your asthma condition, so thereby they can be helpful to you in case of emergency. So thank you, Dr. Graham, and I appreciate the opportunity to participate on this panel.
Thank you, Charmaine. We're now going to hear from Sandra. Sandra, we'd love to hear about your experience, your husband's experience as COVID survivors as we shift the conversation to COVID-19 for those living with underlying respiratory conditions.
Thank you so much for the invitation to be with this group and also to hear the stories of the men and women on this panel. I've got to tell you particularly the story about having lost a little boy. I just don't have the words. I've been asked to take all of you with me on a little journey to a horror story called, in my mind, When COVID Comes to Call. COVID arrived in our family's life late February, and it attacked my husband and made us think, because it's sneaky, that he had a cold. He had a bad cold, and so we went to urgent care. And at urgent care, the nurse practitioner there that had not understood that Eddie's symptoms might be COVID. So he assumed that he had a bad cold, and he sent us home with a Z-Pack. 7 days later, Eddie wasn't any better, and we came back. As a matter of fact, he was much worse. And the nurse practitioner says, well, maybe we should look at some other things. And by the way, we've got these new tests in, and I should give you that too. It's called a COVID test. So we said, okay. Eddie went through the uncomfortable procedure of having a stick go up his nose. And I was sitting there, I said, well, you should probably put a stick up my nose too, because if he's got something, I've got it. He said, well, you probably don't have it, but yeah, we'll test you. He ordered a test that it couldn't be done at urgent care and said that we should go to the emergency room just to get this test. And upon getting to through the doors of the emergency, the healthcare team there took one look at Eddie and knew exactly what they were looking at. And they took him immediately back into the room behind the desk. And I didn't see him again for a long time, that is days, because what they did is hospitalize him. They kept him hospitalized for a week and fought to save his health, as he had pre-existing conditions, I think you call that. While Eddie is, if you're still with me in this movie that I'm painting in my head for you, if Eddie, while he is busy trying to recover from that, I start to get sick. And then I get sicker. Now I know what he has got, and I'm worried about me. So I start to get sicker. And while I still am in charge of myself, I take myself to the emergency room. And now they've got tents and trailers sitting outside the hospital, and that's as far as you get. And they tested me here, there, and yonder, and took my vitals and determined, yes, I was sick, but perhaps not sick enough. And so they sent me back home with instructions on how to monitor how sick I was getting, so that when I got what they considered to be sick enough, then I should drag myself back there. So I simply went home to get sick some more. The sick some more were two measures that I can remember that I was told to do. Watch my temperature if it got to a certain level, and if I couldn't breathe. The temperature got to that level and worse. And the business of not being able to breathe was something that I had to figure out on my own. And I figured out when I got to the point where I had to think about pushing air in and pulling air out, pulling air in and pushing air out, I was having trouble breathing, along with the general business of being just low sick. I called an ambulance to come and get me because I was weak and sick and coughing, by the way, with a racking cough that was so violent, everybody. I felt as though it was going to crack my backbone with every one of those kinds of unproductive but violent coughs. The ambulance came, and I swear they sent the oldest old truck they could find at that point, it felt like to me, but I had to literally walk out of here, not be carried out on a gurney, but walk out with the paramedics and then climb into this raggedy, rickety truck. And it took me to the hospital, where upon arriving, they put me on a gurney this time, and I'm rolled in to the emergency room. And there I saw on the walls of the emergency room area, people lined up on the walls on gurneys. Just, it appeared to be the whole place was just covered with people. The man who was a paramedic for me, that's when his experience kicked in, and I started to get a break, because he went back there and said something to somebody, and because of his relationships and whatever he told them about my condition, they actually wheeled me into a room. And it was in that room that I spent the cold nights with IV drip and all sorts of monitors on me, waiting for a bed to open up upstairs, I was told, in the wing where I would be. There's one other thing to let you know. While a physician came in to see me, he said, well, you're sick for sure and you got COVID for sure. I can make a case for you to stay in the hospital or I can send you home. What would you like? I said, you make a case so I can get some care. And those are the kinds of decisions back and forth. I'll tell you more quickly that what we did was Eddie recovered enough to be sent to recover in quarantine at our son's apartment by himself. And then upon getting out of the hospital, I was sent home. Eddie and I were recovered separately. There were so many things that I don't have time to let you know about the horror story of when COVID came to call. I was so sick. My sister suggested that I ask the hospital before I was released for a sociologist, the sociology department, to send me a visiting nurse, since I would be at home by myself, to monitor me and let me know how I was doing. The hospital resisted that at first, the social worker department, for reasons I don't know. But when I was insistent, they said, well, your insurance will pay for it, so we will send you someone to look at you and let you know how you're doing while you're at home by yourself trying not to die. Now, what I want you to know about all of this is that Eddie and I have recovered. We do have residual symptoms that we manage, and we are listening to the news on the regular and seeing that, but for the grace of God, we would have been in some of those body bags that are all over the place and in our lives today. We also want you to know, I want you to know that as I look back on the experience, everything that was wrong with the healthcare system that I thought was probably pretty good showed itself in the time when it was needed the most. And then again, some things that were wrong with me and us showed ourselves. We were entirely, in my opinion, too compliant with the attitudes of the people who were trying to figure out what to do with us, when we both knew that he was, and then eventually I was, good and sick, low sick. And the system itself seemed to be about the business of not talking about taking us in for care until we got to some level that it considered low enough in the way of sickness. So what I want to let you know is that there are people who are sick and people who are dying because of a misidea that somehow or another Black folks like me, can take it. We can hang on, we can do without until we get to a level of measure of whatever critical care is. And they don't understand what you've discussed on this conference, that we have underlying conditions and all sorts of other reasons why many of us will not survive whatever they consider to be the critical care threshold. And then finally, because I have to leave this conversation at this point with you, I'll ask you to exit the horror theater with me, a Black like me with COVID, and let you know that everything about what it takes to fight this is going to require two things. It's going to require a facing of the reality of it, that this thing is deadly and it will kill you. It's trying to kill you. And the other part of it is that while the discussion is going on whether or not we take the vaccine or not, the real discussion, in addition to that, is will we get the gold standard care that is required on the other side of the injection for when things happen as our bodies try to adjust to it. If I'm going to get what they get at Walter Reed, if I'm going to get what they get at Cleveland Clinic, if I'm going to get what they have at Mayo, then I am able to think that I can probably withstand whatever the rigors of the vaccine might bring. So without that, without the gold standard of care throughout our community, so COVID can't get in anywhere where we are, then we are at risk on a higher, unconscionable and unethical level. And I know we will do better than that. Thank you.
Well, Sandra, this is when I wish that we were in person so that we could give you a standing ovation, because I feel that that is the emotion that your story evokes. And so I just want to thank you for being so transparent, for sharing your journey, your family's journey with COVID. And I want to ask you just one question. How do we instill trust in Black Americans when it comes to COVID and COVID vaccine? How would you advise that we begin to instill that trust?
Well, a couple of things. Reverend and and others have talked about what is needed, and it is. I want to simply add to their very wise counsel is that we must insist that the industry, the medical industrial complex industry, do the right thing. You see, we know what the gold standard of care is. And so in addition to bringing, here's the medicine you must take, then it must bring the wraparound resources that any patient would need in order to survive, not only the disability or the disease or the incident itself, but the ongoing quality of care. So when you come in the new time here, saying, I am here, make sure the entire organization of your medical system is backing you up, because we're not just looking at you, we're looking at who's with you. Right now, there are 3 companies that I can remember, AstraZeneca, Pfizer, and Moderna, that are bringing vaccines to Americans here in the United States. And Dr. Fauci is, of course, the unchallenged leader of what the science and the healthcare messaging needs to be. But have they lifted the face and the voice of Dr. Kizzmekia Corbett, who is one of the chief leaders of the creation of the vaccine? And so when we say Black like me, I need to see Black like me in the business of the creation of the product, as well as the promise and the delivery of the medical industry, and all of you who are caregivers that require that you must stand up in total force for highest level of care to Black community. Do that, and then we will know that you are going to be with us for the long haul of whatever this brings.
Thank you. Thank you for that very honest feedback. So this is the Johns Hopkins Coronavirus Resource Center tracking, where, again, a reliable resource where so much of this research and care has been at the forefront of our nation's advancement when it comes to COVID-19. And if you've not seen this COVID-19 dashboard, it really is the epicenter of tracking both global and US, and seeing those trends across different regions of the world, as well as throughout our country. I'm going to turn it back to Dr. Graham so he can speak specifically about some of the racial disparities in COVID-19 and some of those underlying issues. We will be going for about another 10 or 15 minutes, and appreciate you all accommodating us with this additional time. Dr. Graham?
And let me add my thanks to that. But again, racial disparities in the COVID-19 pandemic have been evident from the start. I was pleased to write an editorial early in this and just looked at New York and the disparities in terms of minorities. And basically that has persisted. So this is a recent data cut, and you see that about 61% of cases are white, but 51% of 51% share of deaths and a 44% share of cases, okay? Blacks, only making up 12.3% of the population, make up 21% the share of deaths and nearly 20% the share of cases. So right there, you see both prevalence, that is how many people have it, and deaths much higher than would be expected in the population. And the situation is very similar for Hispanics, less so for Asian Americans. So what seems to drive this? Well, low socioeconomic status. You know, again, I mentioned earlier today that about 30% of households, 30 to 40% of households are already facing food scarcity. So we're seeing all these things combined with things like substandard and overcrowded housing, harmful environmental exposures, limited ability to socially distance. Early on, if you look at New York, when you saw so many people dying so rapidly, there was a high percentage of minorities that lived in crowded housing, had essential patient-facing jobs, were riding public transportation. So they're in overcrowded housing, transportation issues, they have all kinds of provocative exposures, and they can't socially distance even when they return home. And they rely, like I said, on public transportation. This fact that nobody kind of paid too much attention, but these were the people that everybody was passing, because they were the people that do the day-to-day that keep the rest of us kind of moving through. But these patients were more likely, or these people were more likely to have inadequate or absolutely no health insurance. And most of them were working. And don't get me on the how we've got it ACA, but I mean, that's the kind of issue. So how do we do better, okay? Well, there's got to be a path to achieving health equity. And we have to. I think everybody that's listened to this and just, you know, I'm humbled by the people that spoke, especially with the technical difficulties I was having. But you've heard very clearly, okay, from different angles, social and economically, why health equity is so important, okay? And what determines that? Well, you got to have adequate housing. Your housing shouldn't be provocative. It shouldn't be something that makes you sick. Educational opportunities. We have to break the chain that school funding is tied to property values. So affluent neighborhoods get more stuff, get more schools. Everyone paying taxes should have equal opportunity in our public school system. Quality, affordable care. Without getting political, the Affordable Care Act was not perfect, but it did not need to be gutted. It should not be under attack. We are the richest, or one of the richest countries in the world, and one of the very few countries, first world countries, that don't have a national-based healthcare guaranteeing access to most, if not all, of its citizens. Okay. Then environmental quality, we've talked about that. We've also talked about stable income and job security. But the things that I went through kind of long-winded, those are the things, safe housing, okay, equal education, access to good health care, food. These are things that seem very basic to me.
Great. Thank you, Dr. Graham. So we're going to have one additional polling question. Does having asthma increase my risk of getting COVID? So let's go ahead and launch that question now, and you can answer and log in your response. Does asthma increase your risk of getting COVID, of actually contracting the disease? So we'll give it just a couple of minutes. We still have well over 500 people on the line. Really appreciate you all participating and sticking with us in the last hour of the day for many people. So let's go ahead and close the poll and share the results. So the results of the polling say 54% say yes, asthma increases my risk of getting COVID. 46% say no. So actually it's quite split. Dr. Graham, share with us what the data would actually say about contracting COVID.
Well, the data is kind of mixed in terms of contracting COVID, but it does seem that there seems to be more asthma patients who do contract it. We also know that asthma patients who are poorly controlled at the time of admission do not do as well, and that has been a comorbid condition. So moving on, we look at the impact of chronic disease and other factors. Well, adults over 65 physiologically have lower immune function. That's a reduced ability to effectively fight infections, to include COVID. They also have an increased inflammatory response. We talk about a lot of diseases having chronic inflammation at their base. Sometimes that excessive inflammation can be a problem. And so with these patients would have increased inflammatory response causing increased organ damage. And when you talk to people, talk to a couple of ICU doctors, they say it's a great disruptor. These patients come in with marginal heart function, marginal lung function, pre-existing conditions, and they spiral down because COVID is disrupting all those kind of control mechanisms. They have complicating pre-existing conditions. So if you come in and you have something as serious and as potentially lethal as COVID, and you already are in congestive heart failure, it's a big challenge, okay? Same with kidney or lung conditions. Often it's made worse by a serious infection. We've known that in asthma for years, and any type of respiratory infection always would cause asthma to flare up. We also know, you see the prevalence of older people who are succumbing. As we grow old, our lung loses elasticity, so lung function, the flows derived from passage through those airways, begins to decrease with age, making older adults unable to breathe without high levels of oxygen and or assisted ventilation sometimes due to the inflammation produced by COVID-19. So the best answer to the question that was posed is that if you have poorly controlled chronic lung disease, to include both asthma and COPD, and reduced lung function, if you have those two things, so that means that you have those two conditions and you're not optimally controlled, this increases the chance for respiratory failure due to COVID infection, the respirator and all the things that go with that. If you have poorly controlled heart disease, and this is something that the guys described, my intensive care fellows, they'd come in and these patients would go, some of them would go sky high in terms of hypertension and then go into failure. Or some patients just with the lack of oxygen, the stress of breathing would go into heart failure. So they said that poorly controlled heart disease or poorly controlled hypertension, and I can speak to that fact, I'm well controlled now, but it took a lot of medicine. They would describe patients coming in and blood pressure going so high as to make the heart be decreased in function. So severe lung infection, secondary infection may result in a heart failure, and that associated with a threefold increase of risk of death. And you've all seen the pictures of people on the respirator. Poorly controlled diabetes is also a problem. This has been associated with a threefold increase in death. Obesity is a factor. Obesity is an inflammatory disease, to consider that. But that's been associated with a possible blunting or limitation of the body's response to severe infection. So it blunts your reactions that your body normally has to contain infection. We know that chronic neurologic conditions, okay, if you're weak, if any neurologic condition produces weakness so that you breathe less efficiently, you're more susceptible to a lung infection or complications of that lung infection. So we consider these diseases that you see here without reading them. Motor neuron disease and myasthenia gravis may not be very familiar to a lot of you, but these are things that are associated with significant weakness, a loss of the normal kind of controls in your body for breathing, but also a lot of other issues to support breathing. These conditions are also associated with being chronically ill with weakened muscles, so that the lung infection caused by COVID actually takes advantage of that. The patients can't clear secretions. And many of these cases have already been treated with anti-inflammatory agents that may in turn, while very good for these chronic diseases, may work against the body's ability to treat infection or respond to infection. So it's like an evil stew that somebody constructed. Next slide.
We advanced. This is the immune system slide.
Okay, all right, sorry. There's a delay on my end. So if we have weakened immune systems, we know that patients undergoing chemotherapy for cancer, one of the things we do is we have lessened their response, to the effectiveness of their response to infection. Individuals that have primary immune deficiencies who have chronic weakened immune system, and this includes patients with HIV or AIDS, patients who have received organ transplants because they're requiring very heavy, oftentimes anti-inflammatory agents to prevent rejection. So all of these have diminished. I just lost the slides. What's going on here? All of these patients have diminished responses.
So,
hello?
Yes, I'm here, Dr. Graham. I'll take over
I'm
here.
sorry.
It's okay.
I don't know what happened.
That's all right. Not a problem. I'll continue on. So what can really be done now? What are we stepping forward and trying to address in the gap? First of all, access to COVID testing. We know that we need timely result reporting. It's not okay to wait days, weeks, months to get the result of your COVID testing. And that's why we've been trying to get the more accurate PCR test, but in that 48-hour window, a 2-day turnaround at the very least. And so that's been a real effort of the Not One More Life program and of our COVID testing, and what we're demanding of government to do across the country for the underserved communities and for communities of color. And then also the contact tracing. We need to continue also to screen for comorbidities and risk factors that could be associated with this excessive COVID morbidity and mortality. So those are the things that Dr. Graham just spoke about, whether that's cardiovascular disease, hypertension, underlying lung disease, diabetes, or obesity. Certainly age matters, and the medications that a person may be taking on an ongoing basis matter when it comes to being at risk for worsening of COVID morbidity and mortality. And then we need to use validated tools like the AirQ tool or the capture tool that we've used in our screening program to identify these people and to support them through the experience of living with COVID, of walking through that journey, just as Sandra and her husband did back in February. And then we need to continue to enhance that functional health literacy level in the context of COVID. How do we say things that are in a meaningful way, that aren't too flowery in our words or unnecessary? And so how do we keep it simple, as Dr. Graham encouraged us to do? And that really is through Disparities education. So it's taking programs like Not One More Life and actually sharing those throughout the country. It's things like the webinars that Dr. Graham has done on asthma disparities and different responses to therapy, as well as our COVID-19 and asthma webinar addressing health equity. It's articles in magazines like Allergy and Asthma Today, and certainly throughout a host of different traditional media outlets that we have employed, as well as our Healthcare Disparities webpage at Allergy and Asthma Network, where we've got health literacy tools, asthma resources and COVID-19 information for every community, but especially for those that are living in communities of color and the Black community. So Dr. Graham, really it comes down to this health belief model that you shared. Share with us a little bit about that.
Sure. So if we really want our patients to be part of the team and we want to maximize outcomes, it really is a partnership. And that partnership means a transfer of certain concepts. And we find that beliefs that influence willingness to follow preventive therapeutic recommendations are good things. And what does that take? Well, you as a patient, and I'll be a little transparent, I have hypertension, okay? I also have an artificial heart valve, okay? I take some medicine. I used to have a cholesterol problem. I realized, as you should if you're on medicine, that I'm susceptible to this health problem. So it's not something abstract, it's something that I'm susceptible that can take me out or limit what I can do. I have to realize that the threat to me, my health is serious, that it's not just something the doctor's telling me. I could die. I could be incapacitated. I could lose the ability to interact with my family, exercise, do whatever. And this is a calculus that comes into this. This is a math problem. And we as physicians have to be in partnership with patients. We have to, as a group, accept, or as a team, accept that the benefits of what we're recommending our patient to do outweigh the costs perceived by the patient. It may not be monetary. We learned long ago that if we had a medicine that we gave 4 times a day, that we could give effectively twice a day, patients were going to take it more, okay? And it fits in with their lifestyle. So those things are important. Those beliefs that we have to work with patients together, that's what influences willingness to follow preventive therapeutic recommendations. And quite frankly, we as physicians sometimes don't build this at the front end like we should.
Absolutely. And that's what we hear so consistently. And that's why we have worked through the Not One More Life Trusted Messengers project to empower people of color with this information in a way that is meaningful. And so you can see some of the resources that we've developed and that are available at our website here on the screen. Understanding your heightened risk for hospitalization, understanding some of those underlying health conditions that may increase that risk, certainly knowing what you can do, the steps that each of you can take, that each of us can take to ensuring that we are protecting ourselves and our loved ones and truly our own direct community, because we all have that responsibility to not only care for our own health and well-being, but those that we love and the communities that we live in and serve. And so that really is why we are reaching out with this project, Black People Like Me, Black Like Me, and introducing an online place that's designed just for you, just for that community. And our success will come from this ability to connect over the next 6 months. And so we're inviting you to be a part of this private Facebook group, Black People Like Me, where we will explore thoughts and feelings about how we advance and do this work together. We believe that this can become a trusted resource that can allow you to ask those questions directly of experts like Dr. Graham, like Sandra, like Reverend Stinson and Charmaine, and take part in conversations with people who are walking through this journey. Even today, we've had far too many questions to share all of them. And so we're going to continue to request of you to be engaged, to be creative. On this closed private Facebook page, come along the journey with us. Post a drawing, a photo, a quote, whatever you want to discuss. That's what we will take forward into these future meetings. Be social. The success of the community really will be driven by your engagement. So ask your questions, post your thoughts and feelings, join the conversation. Don't be afraid to, put it out there. That's why we started this conversation and why we gathered together this group today of hundreds that are concerned and ready to move forward with addressing these health inequities. And then stay engaged. We hope that this will continue to create and communicate with all of us over Facebook in the months ahead. This is going to be a wonderful opportunity to develop artwork and to celebrate the progress on a month-by-month basis as each of you tune in to the Black People Like Me webinar series. Please use the hashtag that you see here on your creative posts so we can find them more readily if it's on your personal Facebook or on the closed Facebook group, and we'll be sending that out in a communication after today's meeting to everyone as well. I just want to stop and thank our advisors who have started this effort, who actually came together to help us co-develop the first piece of art to share here. And so that was Shernette, who is on the line, and you can see her there in the center, as well as Charmaine and Edwin, who you heard from earlier today. Over the course of the next 6 months, you're going to hear from many others just like you that are walking through this journey. But this is their first rendition of a creative image that shows their hopes, their aspirations around this effort and condition. And it says, my mission in life is not merely to survive, but to thrive, and to do so with some passion, some compassion, some humor, and some style. Such a powerful quote by Maya Angelou. And again, I think that, you know, this inclusion of this image of somewhere over the rainbow, the skies are blue, and dreams that you dare to dream really do come true. We hope there's a day where there is no more asthma or COPD. We hope and pray that the day comes when COVID-19 is a thing of the past. But until that time, we are here. We are here as a community to stand together, to fight this pandemic, to fight this chronic condition that is robbing us of far too many people each and every day. And so we're hopeful. Just yesterday,
Wow.
the very US COVID vaccines were delivered in New York City. The first 2 vaccines went to individuals that are working on the front lines of healthcare, individuals that are Black Americans. And we are so very excited about the way that this will continue to advance. Now, we want to hear from you. How do these images, how do these stories resonate with you? Is it evoking that trust that Sandra spoke about? Is it evoking concern? We want you to be honest. We know that there are historical issues of healthcare and trust in the Black community. We realize that. We acknowledge the sins of the past of others that have not cherished and treated people with the respect that they deserve. And we believe that today is the first day that we can move that effort truly forward in our community of those living with underlying asthma, COPD, and other respiratory conditions. And so in this forum, in these efforts over the next 6 months, we hope that you'll come alongside us and really help to reshape that conversation and to change the way that people perceive this area and ways that we can make a true difference in addressing the health disparities that Dr. Graham began speaking about at the outset today. Dr. Graham, would you like to give some just closing comments or thoughts around these images before we close out our time?
I absolutely would. And the first thing I'd like to, I'd like to thank Tanya Winders for her leadership. Tanya is a very humble person. She does so much in this space. Not the least of which is putting up a lot of doctors, okay? But she has a heart to serve, and it's just amazing. And programs like this, quite simply, would not be possible without her and the incredible organization that her network is. And I mean that from the heart.
Thank you.
But just real briefly, you know, a word about the vaccines is try and learn as much. There's a lot of information coming out, okay? We need to do this. I'd like to thank all of you for putting up with a lot of the delays. I'd like you also to really think about, you know, reaching out one to another here. I think a lot of people are living in isolation, and that compounds everything that we see in terms of health, okay? Reach out to somebody that maybe nobody's talked to. Check on some people. Just ask them how they're doing. So many people are in isolation. Those of you that are able, think about donating to some of the food banks. We're facing 30 to 40% by one report of households in America, the United States of America, are dealing with food scarcity. It's not an abstract over there. So give to those things like that. And again, I'm going to let her read the last of these. I go on too much, but I just want to thank everybody for participating. And it's part of our culture as people of color. You know, we hear something good, we pass it on. Drop the word down around the neighborhood. Get it out to other people. Because together, we can get through this.
Yeah. Absolutely. And thank you again, Dr. Graham, for your leadership and for all of the panelists, for the project advisors. Please do complete the program evaluation and the post-test after the event today. Save the date for the next conference, January 14th, 2021. Hard to believe that we are turning the corner into a new year, but it's a new year of hope and a new year that we are looking forward to working together alongside you on this effort. Join our Asthma 360 registry, learn more about that, or the Not One More Life Trusted Messengers program at allergyasthmanetwork.org. You will receive an opportunity to participate in the Facebook page for Black people like me participants. And we also will post questions and answers and the PowerPoint that we were unable to get to today. So we're going to use all of this feedback that you have provided today to create and craft new tools to serve the community. So with that, again, I just want to thank you all for your time, for your active engagement and participation, and wish you well as we go into this holiday season. We look forward to the next 6 months and to years to come of walking together to end the needless death and suffering due to asthma, allergies, and COVID-19. Thank you and have a blessed day.
God bless. Hello?